welcome to your mini lecture on Chapter 6, Mood Disorders. For this unit, you are doing Chapter 6, Mood Disorders, and Chapter 4, Anxiety, Obsession-related, and Trauma-related disorders. I do these two disorders together for a specific reason. One, these are the most common disorders that we actually see in clinical practice. To be specific, we start with mood disorders because depression is the most common disorder that you see. It's called the common cold of mental illness. So roughly about 16% of the population will be, at least meet the criteria for a major depressive disorder at some point in their lifetime. So depression is number one, and then anxiety-related disorders is number two. And so I do these first because these are the most common disorders that you see. The second reason I do them is that there's a lot of overlap between depression and anxiety. So you actually often see a lot of people who have both depressive symptoms and anxiety symptoms together. When we look at etiology, we actually find that there's actually some of the same brain areas, some of the same brain chemicals, and some of the same medications work for both depression and anxiety. So really, these two sort of big categories fit really nicely together. So that's why I do depression and anxiety together. Today, though, we're going to focus on mood disorders, and I have them broken out into two different categories. I want to talk a little bit about the specifics of each of the mood disorders, some subtle stuff, but really you need to make sure that you're reading your text to really get the full breadth of what's going on in this chapter. So one thing about diagnosis first. What you'll notice with most diagnoses is we really look at about three different areas. Not every diagnosis looks at these areas, and sometimes there's other things that you have to take into consideration. But usually when we're talking about whether or not somebody actually has a clinical disorder versus somebody who maybe is just feeling down or feeling blue, or somebody who's just an anxious person, the difference between the clinical disorder and just having the symptoms is usually these three things. So typically we look at time. So oftentimes in diagnoses, you'll see that there's a certain amount of time that has to pass to have these symptoms for this to occur. So for example, in major depressive disorder, you have to have the symptoms every day, most of the day, for at least 2 weeks. If you're only depressed for 1 day, you do not have major depressive disorder. You have to have it for 2 weeks. In other disorders, what you're going to see is that you have to meet criteria for 6 months at a time, or 3 months at a time, or 12 months at a time. There's going to be some sort of time length that's usually going to be part of the diagnosis. In addition, sometimes frequency is a part of that. So for example, when we get to eating disorders, you'll see that in order to be diagnosed with, say, something like bulimia, you have to have a binge eating episode 3 times a week for, I think it's 3 months now. So frequency and time sort of go together, but you're going to often see that when we talk about diagnosis. That's a subtle difference between a clinical disorder versus again, a non-clinical symptom stuff. Then we get into the symptoms. The DSM, which again is the manual we use for diagnosing, is set up to where usually they give you a list of different symptoms you could have, and you have to have a certain number of those symptoms in order to have the diagnosis. Again, for example, major depressive disorder, you have to have 5 of the 9 symptoms listed, again, for at least 2 weeks in order to get that diagnosis. So that's how we typically diagnose. There's a few disorders that aren't like that, but most of them is a list of symptoms. Finally, dysfunction. Remember from Chapter 1 the definition of dysfunction. It means that you either have some sort of distress, so you don't want to have these symptoms, you are concerned, you are significantly distressed about having them, or you have to have some sort of impairment in your life. So maybe you're fine with sort of what's going on in your life, but it's hurting your relationships, or it's hurting your occupation, or it's hurting your education, something along those lines. So in almost every diagnosis, you'll see a line or a criteria that says it has to have significant impairment or significant dysfunction in the life, which is defined as personal distress or, again, some functional issues. So this is how we diagnose in general, and this is how you in general read those DSM-5 criteria when you're diagnosing something. So let's get straight into mood disorders. Again, I've divided them into 2 different big categories. The first one is what we would call the depressive disorders. So again, mood disorders is about your mood. And mood can be sort of okay, it can be really, really high, it can be really, really low. The depressive ones, sometimes called unipolar disorders, are just the really, really low stuff. So as I've already mentioned, major depressive disorder is the common cold of illnesses, or at least mental illnesses. There's two different types that you could have, though. You could have what we call a single episode, which means it's only happened one time in your life. So you're chugging along the world just fine, and then all of a sudden, for various reasons, you get depressed, and you're depressed for a couple of weeks, and you have the clinical symptoms, and it's causing problems, and it only happens once. That's a single episode. Some people will only have one single episode their entire life. Doesn't mean that they never get sad again. You'll get sad again, but you only have the actual clinical disorder once. About 1/3 of people who have major depressive disorder are considered single episode. The great thing about that is that it also means that once you get diagnosed with major depressive disorder, it doesn't mean that you always have major depressive disorder. So you could have it for a while, get treatment, no longer meet the criteria for it, and then boom, you don't have major depressive disorder. It doesn't follow you throughout your whole lifetime. There's a few disorders that actually, once you get diagnosed, you're kind of always considered having it. It just maybe sometimes goes into remission. 2/3 of people, so the majority of people who do have what we call MDD, major depressive disorder, and you'll see me use these acronyms all the time, so get used to acronyms, will have what's called recurrent episodes. So they had it once, it goes away, then they'll get it again. So again, it's kind of like a common cold, right? You get a cold, it goes away, but then sometime in your life you might get a cold again. Same thing. So major depressive disorder, for most people, 2/3 of people, they have these episodes throughout their lifetime. They also have long periods of normacy where they're not depressed, but they're going to have a second episode. You're more likely to have a second episode if you have one. So that's major depressive disorder. Again, pay attention to the details of the diagnosis. How long, what the symptoms are. Don't worry about memorizing the symptoms too much, but just have an idea of what it is, things like that. The second one that we're going to talk about is called persistent depressive disorder, or dysthymia. Dysthymia is what it used to be called. They just sort of recently changed the name to persistent depressive disorder, but dysthymia is still an active name, it's still a valid name. This is basically sort of depression light. So you don't have to have as many symptoms. You really only have to have a couple of symptoms in order to classify as persistent depressive disorder. However, you have to have it for 2 years. So persistent depressive disorder is a milder form of major depressive disorder, but for a longer time. So it's sort of a chronic and less severe form of it. Both of these are devastating disorders. Both of them can lead to suicide. There is a section in your textbook on suicide, so make sure you're looking at that. So those are the unipolar ones. Let's move on to bipolar. There's actually 3 different types of bipolar that we're going to talk about. And again, the devil is always in the details. So what separates bipolar from depression is the presence of elevated mood symptoms. And so in particular, if we're talking about bipolar 1, we're talking about a manic episode. So a manic episode, there's lots of different criteria for it, and again, you have to have a certain number of those criteria to qualify, but it's a shorter duration, only 1 week, or hospitalization. If you get hospitalized for a manic episode, it still counts, even if it hasn't been a week. With a manic episode, it's that elevated one. You have an inflated sense of self-esteem, so much so that it's grandiose. You just think that you're awesome possum, and you're the best thing that ever came along. You have, you become very productive, but it's not always quality. So you start doing stuff all the time. You're like, I'm doing this, and I'm doing this, and I'm getting things done, and I'm checking off things off my to-do list, but it's not always the best. So you might write 5 papers in a night, but they might not be your best work. We have cognitive issues like called a flight of ideas, where things are just flying through your brain and you just can't control them, and you're just, Oftentimes people talk really fast, and it's sort of like if you've had too much coffee or too much caffeine in a day, and you're like, and you feel all wired. It's kind of like a manic episode. Manic episodes actually feel kind of great. Most people love them. But the problem with them is they also come with risky behaviors. So oftentimes people will go out and do shopping sprees that they don't have the money for. So they'll blow thousands of dollars in a day on stuff that they don't need, and then there'll be some financial consequences later. Or they do some risky behaviors, such as like speeding. So not necessarily heavy criminal stuff, but they might drive really fast, or they might engage in risky sports. One of the worst things that oftentimes people do is they become really promiscuous, and they go out and they have unprotected sex. Oftentimes they're married, but they go out and they find these partners, and they're just oversexed at that time. And so there can be some heavy-duty consequences to relationships. So manic episodes is what really classifies bipolar 1. Most people with bipolar 1 will also have depressive episodes. They don't have to, but most of them will also have that. And that's that swing that we often talk about, where you're really high up, and then you go really, really low. So if this is sort of normal mood, right here, you start in this manic state, and you're feeling, I feel so great, nothing can hurt you, and you're doing all these risky things, and then the consequences come. Your partner finds out that you've cheated on them. The credit card bills roll in, or you realize the credit card bills will roll in. And then all of a sudden you sort of fall into depression. And usually depression lasts longer than the manic stage. And oftentimes I talk about the fact that the higher the people fly, the higher that manic episode goes, oftentimes the more depressed they become. And that's where it becomes really dangerous. And like I said, oftentimes they become actively suicidal, and that's where hospitalization comes in. So that is bipolar 1, super, super highs. Bipolar 2 is a little bit different. It's called a hypomanic episode. And so a hypomanic episode is similar to a manic, but it's less severe. So instead of going out and having sex with 5 different people, you do a lot more flirting than you normally would. You just become really flirtatious. Instead of not sleeping at all, which often happens in a manic episode, you only get a few hours of sleep, or you only get 4 or 5 hours of sleep, but you're still super productive. So hypomanic episodes are like less severe, and they usually last about 4 days, as opposed to the 1 week up here, in order to classify it. Bipolar 2 people also have depressive episodes, so they meet the criteria for depressive episodes. Whereas again, bipolar 1, maybe they'll probably be there, but to classify as bipolar 2, you have to have both hypomanic and depressive episodes. Cyclothymia is very similar to dysthymia. That's why I still like the word dysthymia, because you can connect them. It's basically a chronic but less severe form of the bipolar. So you have hypomanic episodes, and you might have some depression as well, but they're just not as severe as the bipolar up here. And again, they have to last for 2 years. So for 2 years, you're kind of riding a roller coaster where you have periods of just sort of sadness, maybe not depressive episodes, but just sadness, and then you have periods of just heightened productivity. So those are sort of the 3, and that's how you separate them out. We have 2 other disorders that just were put in the DSM last year when the new DSM-5 came out. It's called premenstrual dysphoric disorder. And so this is basically mood swings and irritability that occurs for women. It's only diagnosed in women right now, the week before their menstruation starts. So PDD, or PMDD, as it's been referred to, is sort of that time period. It's not just that you get cranky, but there's specific criteria, specific symptoms that you have to have, and so it's really elevated irritability, cognitive issues, mood swings. And then it ends the minute when your menstruation starts. So a couple days into your menstruation, all of it goes away. That's how it's different from these other disorders. So that's PMDD. The other one is disruptive mood dysregulation disorder, DMDD. We have that in there because a lot of children were actually being diagnosed with bipolar disorder. Here's the thing about bipolar disorder. Once you have it, you always have it. If you get diagnosed as bipolar, you will always be bipolar for the rest of your life. You can control it, you can use medication, you can use different treatments, but you're always going to have bipolar. So if you are diagnosed as bipolar at the age of 8, that diagnosis follows you, unlike major depressive disorder or something like that. So that's not good, because there's a lot of things that are happening to 8-year-olds that maybe are very different, and maybe as an adult they won't have bipolar. Maybe there's just something going on in children. So understanding mental illness in children is different from understanding it in adults. So they came up with this idea of dysregulation mood, or disruptive mood dysregulation disorder. It's for children aged 6 to 18, and it's basically children that have problems with impulsivity. So again, they're having mood swings, and they're just reacting really, really strongly to things, more so than would be appropriate for their developmental age. And you've always got to take their developmental age into account. A 6-year-old is going to react differently than a 10-year-old. So is it normal for a 6-year-old to act like this? Is it normal for a 10-year-old to act like this? So that's where the dysregulation disorder comes in, that it really helps with those children who are having those mood swings and that irritability and those impulsivity issues without giving them a permanent label like bipolar. So those are the major diagnoses in this chapter. I also want you to pay attention to a couple of things in the text. One, look at the social cultural issues. Particularly with major depressive disorder, we see huge gender differences. By the time people are adults, women are twice as likely to be diagnosed with depression than men are. Why is that? Look at some of the evidence and some of the theories for that. Also look at the etiology and the treatments. The etiology oftentimes is very biological. We know there's some neurotransmitter stuff going on. We know that there's some brain areas that are going on. But look at the psychological explanations as well, particularly the behavioral, learned helplessness, and the cognitive, the negative triad. Those are some major theories that you should be aware of. So learned helplessness is a behavioral theory, helplessness, there we go. And the cognitive theory is the negative triad, or the cognitive triad. And basically what that means is that you have a very negative view of yourself, of the world, and of the future. So we look at sort of these behavioral and these cognitive etiologies, and then you can connect them actually to the treatments. So when we talk about treatments for most mood disorders, of course medicine is in there. Most of you know a lot of the common treatments, Prozac, Seroquel, things along those lines that we use to treat, again, major unipolar and bipolar disorders. But also cognitive behavioral therapy is really very, very effective. And so you can connect what we do in cognitive behavioral therapy with these etiologies, this idea of how behaviorally and cognitively depression occurs. So make sure you're looking at that, and if you have any questions, go ahead and post them. I'm happy to help you maneuver through these chapters because it's difficult stuff. So good luck.